Sure, we can get started. Patty, I can just see the first, slide. I can't see the agenda, but maybe that's okay. But maybe that's okay. I'll just welcome everybody. It looks like we have 25 people on, so that's really exciting. Hi, everybody. Welcome to our Trauma-Informed Care Talk with Dr. Griffin and the Humboldt Rise Project team and Dr. Stockton, Hannah Lippy. We're very fortunate to have these folks to work with during this time that we've continued this project. And so I had a little reflection. It's half of a reflection that I found and then half that I just wanted to add. So I just wanted to share my thoughts with you guys on this. Always do your best. Your best is going to change from moment to moment. It will be different when you are tired as opposed to well rested. Under any circumstance, simply do your best and you will avoid self-judgment, self-abuse, and regret. And I just wanted to add my thoughts. I typed them so I could say them correctly. The simple quote resonated with me because all everyone is trying to do right now is their best during this time that no one saw coming. Whether we're isolated at home with our kids and family or at work with each other and our patients, having to wear a mask for 12 hours, our best might just be that we're doing okay and good enough for now. And having to be okay with that, without judging ourselves and others, and being patient and kind to each other. Our pregnant patients with substance use disorder are struggling even more now with all the changes in the world. This trauma-informed care talk will help us understand substance use disorder and how we can interact with our patients with compassion, patience, and understanding. Just wanted to share that as our start to our meeting. And so I'll turn it over to Patty to introduce the Humboldt Rise Project team.
Hi, everyone. I'm Patty Torres. Many of you might already be familiar with the Humboldt Rise Project. If you're not familiar with the name of the project, surely you're familiar with Hannah. She is the care navigator. So the Humboldt Rise Project is a grant-funded project through the Wellbeing Trust. It's a multi-organization project with the Department of Health and Human Services, the California Center for Rural Policy, St. Joseph, of course, and the North Coast Health Improvement and Information Center. It is formerly known as the Perinatal SUD Project. That name was pretty horrible, so I'm glad we have a new one that reflects our values of resilience and inclusion through support and empowerment for the pregnant people of our community. This project has several objectives, one of which is to implement early screening in the perinatal setting to identify women who may be at risk and get them connected to Hannah to help them access services in the community. And through that process, we also learned that it's really important to do what we can to provide support and education to the community about how to have these rough conversations, right? Because oftentimes it's not just about screening, but it's the conversation that leads up to the screening or that, follows the screening if a patient is identified with being at risk for substance use disorder. So that's why after working together, we thought we have experts in our community, very fortunately, Dr. Carrie Griffin and Dr. Candy Stockton on the topic of substance use disorder in pregnant people and trauma-informed care. So we're really happy that we put this together for all of you.
Thank you for that, Patty. Thank you for that explanation of Humboldt Rise. It's just an amazing project that I'm proud that is part of our now really that we've connected with you. And so I just wanted to introduce everyone. It looks like, for the round of introductions, most of everyone knows all of us. And so you can see the list there. And so Patty, okay, yeah.
All right.
Okay, go ahead with, so will Carrie take over now? Okay, go for it.
Yeah, I can. So
Okay.
what you'll see here is this is originally designed, we had planned this really beautiful 4-hour trauma-informed training for everyone, and we are still planning to do that, and that will be very interactive and involve a lot of small group work. However, COVID. So here we are on Zoom, and this is a much smaller offering, but we're hoping that we've given you both some theory that's substantial. I like to call it embodied theory, so something you can really take with you. And also we're going to go over some cases. So we want to make this really germane to the work that we're all doing. So just to start by defining trauma. So I feel like trauma is one of those things that, like, you know it when you feel it, you know it when it happens to you. And the truth is that trauma will befall all of us at some way, shape, or form in our lives. But its technical definition is a distressing and overwhelming experience. Now, where that becomes really important to the work that we're doing is that there's two different kinds of trauma. There's shock traumas, and this would be an avalanche or a car accident or a tsunami experience, or, you know, really the most common things are falls and car accidents. Or what we end up working with patients a lot is really developmental trauma. And these are pervasive traumas, so cumulative experiences of abuse or the perception that your physical and emotional well-being is harmed. And so we won't go over the ACEs or adverse childhood events, but I know for those of you who come to other talks that the Humboldt Rise Project has sponsored, we've talked a lot about ACEs. And so this includes any experience of physical, sexual, emotional abuse, even just the experience of growing up in poverty and lack of resources. And the reason that all of these things are important to be aware of is because any traumatic episode can lead to overwhelm. It can lead to a condition where an individual is not able to call on their innate ability to come back to their set point, to come back to their neutral, and instead they adopt a variety of different coping strategies to reckon with the fact that there's been constant, overwhelming trauma. Next slide. So the reason we care about this is specific for this population. One of those maladaptive coping skills that people often turn to in the wake of trauma and pervasive developmental trauma is substance use disorders. So any kind of addictive tendency. It is important to remember, of course, we're talking about substance use, but certainly addiction and addiction-based behaviors can take any number of forms. There's relational addictive patterns. There are behavior-based addictions like gambling. Certainly for this, we're talking about substance use. But trauma history leads to maladaption, which can include substance use disorders. This is even more germane for us because when you have trauma built into the pattern of your life, that means that anything outside of you, it could be something in your environment, a person you interact with, or a certain way that an interaction happens, can lead to this external event, the reignition of that inner sensation that you've lost safety. And that can show up in the nervous system in several different ways. The three most prevailing patterns being fight, flight, and freeze. And fight, we see this when someone comes in and they get combative with us or with our partner, and there's that immediate response to, you're threatening me, well, I'm gonna come at you. Flight, this is the patient who leaves AMA, right, on post-op day 1 when she has been overwhelmed by perhaps a visitor, perhaps she took something that was not meant rudely the wrong way, and people just leave. And then freeze is a little trickier. Freeze is actually really a defense mechanism of the parasympathetic nervous system. So fight and flight are that sympathetic resource. When those don't work, or when you have just exhausted your inner ability to use them, we shift into freeze. And this is where some of that very compliant, people-pleasing, very slow, shut down kind of behavior shows up. So we want to keep those three patterns in mind as we go throughout the rest of the talk. Next slide. So this is even more important because a hospital is basically like a walking trigger factory. Everything we do has the potential to potentially traumatize people, especially in labor and delivery and in the world of birth. So removing clothing, the intimate exams that we do, invasive procedures. So even just placing an IUPC or certainly something as invasive as a cesarean, the inherent power dynamics that exist, no matter what your role is in the hospital, if you're employed there, you're part of that machine and that milieu, and the patient will perceive themselves as being disempowered by contrast. The lack of privacy, think about it. We come in and out of each other in patients' rooms, we knock, we ask permission, but they're really on our turf. Just the sounds and the smells, even for some patients, the smell of strong alcohol sanitizer or strong chemical smells can be a trigger for use or for just being in an environment in the past that was damaging to them. And then one of the main triggers, which is what we're going to focus our shorter presentation on today, is the fact that we are required to ask really intimate questions. People walk in the door in labor or in distress, and we're immediately like, hi, great, tell me your name. Do you use heroin? Can we talk about that real quick? Whoa, that's a lot. That's a lot for someone just to take in. So the way that we can approach those questions, which are so valuable and so imperative for the work that we're doing and for their health, really can affect how we get responses to that and how we're working with the nervous system that's in front of us. Next slide. So there's a couple different rubrics, and we'll actually in our larger presentation use a different one, but one way of thinking about trauma-informed care is the 4 R's. So starting with realization of the fact that the trauma has this widespread impact, and the fact that it has a widespread impact, but inherent within that, there is a path for recovery. Once we realize this, we learn to recognize what does trauma look like in ourselves, in patients, and anyone who's interacting with the patient. How does it unfold in a systemic way? Once we've realized and then recognized on an individual way, we figure out how to respond to trauma by doing sessions exactly like this to educate ourselves and more deeply understand trauma and how to work within it, and also to apply trauma-informed care to the policies, the procedures, and the practices. To do this means that we're actually doing the incredibly important work of resisting re-traumatization, which means that we, as a part of this larger system, can actually be a part of recovery. We can be part of that repair between a patient and larger relationship structures. Next slide. So why don't we do this? Because obviously this is a great thing to do. However, we're human. We work in a structure that certainly doesn't innately support this unless you have very conscientious leadership. There's often a sense that we don't have enough time, and maybe we're just not aware of ourselves in a given moment, or the fact that we could be using this kind of rubric as the foundation for interacting with patients. There's our own misconceptions, and then our own discomfort with a patient who shows up and maybe seems like they have a heavier mental health burden, or they're struggling with some aspect of addiction. Related to all of those things, we think of this almost as so nebulous that we don't have tools and we don't have the training to actually engage with people in this way. Next slide. So the next 3 slides, the first 2 slides I'm going to include just some very sort of every trauma-informed care training that I've been a part of as either a participant or a facilitator has included some of this information from SAMHSA and the American Psychiatric Association that go through what I like to think of as a list of good ways to be a human, which is wonderful, but we are all very intelligent people. You guys are excellent clinicians. You know how to be a good human. So I am going to read off what these are and just talk about them, because they sort of plant a general sense of awareness of how to show up as a trauma-informed person. But then I want to go through a little bit more of a diagram for how I think about having a trauma-informed conversation, which hopefully is a little bit more interactive and relational and might land a little bit deeper. So that being said, ways that we can show up include checking out the environment that we're interacting with the patient in, really encouraging it to be calm and soothing, being relaxed, making it seem like we have lots of time, we're not rushed, working really strongly to engage and develop rapport with the patient, talking about concerns and procedures before doing any intervention, giving the patient choice. I always, 99% of the time, I'm sure I forget at times, but I really work hard when I check someone's cervix to say, just a reminder, you're in control. If you need me to stop, you tell me. And just make that as reflexive a part of my exam so that they just have that reminder. Validate, 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 and once again, validate. Whatever is coming up for that person is real for them, and we will not get anywhere if we don't honor that what is alive for them is alive for them. allow support people to be with your patient. So whoever it is that they're going to develop resourcing in, we want that person in the room with us. And then really getting informed consent. It's very important to name what could happen in a procedure. And without doing that, we really risk losing trust in patients long-term. Next slide. So relatedly, asking a patient if they're ready. This is, again, another way of giving them control. Figuring out how you can help make them feel safe and protected. Do they need to be more covered during an exam? Keep talking to them. This is not just a one-time way. I showed up and I was trauma-informed on point, and now I don't need to do that for the rest of my shift. Of course, this is about relationship building. I encourage them to do what feels comfortable. Again, that's another form of validation. And then this is one tiny phrase which alone really merits much, much, much more depth, but always keep a broad narrative lens on someone's ethnicity, their race, their religion, sexual and gender orientation, and then what other historical or social trauma might they have experienced as part of a narrative of being homeless or impoverished or Native. Always keeping that framework available as we're doing our work with patients. Next slide. So I've said all of those things. Everyone knows that in a perfect world, we do those things for the most part. And so what I was trying to think of that felt like it was a little bit more meatier is, oh, this is fun. There's a weed whacker outside my house. Hope you can still hear me. Let me know if you can. But what I started to think about was how I actually engage with an interaction. And so when I slowed down and started to think about what that feels like for me, I realized that I'm looking at three things at all times and really mitigating the conversation between these three features. So one is the goal. Every interaction with a patient has some intention behind it. And sometimes it's just as simple as you're meeting the patient at the beginning of your shift, they've just come in for an NST, and you notice that their last urine drug screen was positive for methamphetamine, and you're not sure if anyone's ever talked to them about that. Maybe you're just establishing a sense of relationship. Maybe they're there for an inpatient Suboxone start, and you need to do a CAL score. Maybe you are going to be telling them that CWS is coming by later this morning, but there is some specific goal, and I would argue that relationship building itself is even a specific goal. So I've got that intention in mind. The next thing that I'm thinking about is the patient themselves. And when I walk into the room, I'm assessing their body language. Are they curled up in bed in the fetal position? If they're postpartum, where's the newborn related to them? Is the newborn in the bassinet on the other side of the room? Is it, wrapped under the mom's armpits? What kind of emotional state is she in? What's the affect? And on some level, that seems almost like too obvious a thing to name, but it's a big difference if you walk in and someone is weeping, or if they're yelling, or if they've tossed their phone angrily the moment you walk in the room. What are you witnessing, and what information is that giving you? That relates, of course, to their behavior as well. And some of that can be, is someone acutely intoxicated off methamphetamine? Are they really anxious? Are they, fidget spinners aren't as popular anymore, but are they doing something constantly? All of that is giving you a sense of who they are. And then this, similar to the last note of the last slide about historical and social trauma, narrative. I cannot say enough, narrative medicine is its own discipline. And understanding the story of the person in front of you, I really like to start with the present story, right? What brought them into the hospital? Have they just had a baby? What was their birth like? How has this experience been for in the immediate postpartum period of going through Eat, Sleep, Console, or maybe having no prenatal care and then suddenly having a lot of care because they're in the hospital. So starting with that present day narrative and then working into the past. How did they end up from birth until this day as the person sitting before you? And then related to that, where do they want to go? So past, present, future narrative all has so much information to glean to understand the person who's in front of you. And then myself, right? And maybe other than what's my goal for this conversation, and before I assess the patient, I'm checking in with me, right? What mood do I have? Have I slept recently? Did I have a fight with a friend or a coworker? And am I ready to check that at the door? Am I ready to say, cool, that's the space I'm in right now. How do I get back to my neutral center? Because if I walk in with all of whatever that moody baggage is, this will not be as effective an interaction. And then the other comment there is bias. And what are the implicit biases that I'm carrying? I really don't think that we can do the work of shining inner awareness on that enough. Whether it's my biases about substance use or about someone's color or race or religion, we all have that. And it's important to keep interrogating ourselves about it as we walk into a room. So there's those three focal points, right? Myself, who's the patient, what's the goal I want from this conversation? And then I think of those things as happening within this larger milieu of principles. And those things are compassion, safety, and resiliency. So certainly compassion. I really don't believe that anybody showed up in the healthcare field if they did not understand the power and the value of compassion, of suffering with, and recognizing that just sitting in that space of shared heart capacity is wildly transformative in and of itself. Secondly, safety. So we're talking about trauma. We're talking about people who have nervous systems that are maybe revved up and ready to go, or maybe totally shut down. And part of what my job is to create a sense of safety. So for some people, maybe that means I sit pretty far across the room. I definitely sit down and make sure that I'm not standing over someone. And then throughout our conversation, the third thing that I'm constantly trying to do is connect them to their inner sense of resiliency. So I want to keep identifying any part of the conversation where they say something that they're proud of, they say something that's gone well for them. If they tell me that they used to be clean for 2 years, I congratulate them on that and say, that is amazing. Tell me how you were able to do that. What was that like for you and how did that feel? You want to keep bringing the narrative back to everything you see that supports them being a whole, healthy, embodied person. Next slide. Okay, so what we're going to do is we're going to do 3 little scenarios, and I want to hear from you all about these. This is really about accessing our hive mind, because I'll present a sort of trauma-informed challenge, and then we'll go through some trauma-sensitive solutions or things that you could call on in the presence of such a clinical scenario. Okay, so this is a 23-year-old G2P1 unknown LNP presents with contractions. She's had no prenatal care. She refuses to let you check her cervix. She's screaming both like with the contractions and in between the contractions, just all the screams. And she says you have to do something, but will not let you touch her. So I invite you to take yourself off mute if you feel so inspired and share, what would you want to do? This happens like every day. So I know you do things when it happens.
I would think about whether or not she actually needs to be checked right now. And because sometimes it's really hard when they're screaming and out of control with pain, and then trying to assess if she's ready to push the baby out and how quickly we need to get ready, because we're thinking we need to be ready for this delivery to be safe in our mind. But she's out of control right now. And I wonder if she has someone with her for support, if that person could help to calm her and connect with her. What else do you guys think? This is tough. What do you think? Anybody?
This is Rachel, and I find these situations so incredibly challenging. It seems to me like the best thing would be, more often than not, they don't arrive with anyone that's a support, or because they're via ambulance. And the encounters I've had when it's been extreme like this, seems like it would have been more appropriate if we had like one person, one nurse assigned just to focus on her, as far as to bring her down, connect with her, establish that rapport, and then someone else doing everything behind the scenes in preparation for that room. Granted, sometimes it's been challenging to get a provider there, and more often than not, then we're conducting those exams. But it's trying to engage their mind to recognize we're here to help them, and it's challenging. Anyone else's ideas?
I would say let her know that I'm here to help her, and ask her how I can help her feel more comfortable with what we need to do.
Awesome. You guys are natural informed trauma geniuses. Let's go to the next slide. So a lot of what you all just said are included in these kinds of suggestions. So verbally reassure her that she's safe. The word safe is really important. So for people who do, there's a few forms of counseling that are trauma-informed, such as somatic experiencing, or DBT, or neuroaffective relationship model. And there's a lot of good evidence that using the word safe is powerful. People want to hear that. They take it in and they're like, oh, I'm safe. I mean, there's some infant lizard part of us that's just like, oh, okay. So use that actual word. Figure out if there's other physical things that don't necessarily involve touch if you don't think that she's about to crown, right? Water, heat, ice, a cold cloth. Another thing that again comes from the realm of somatic experiencing is orienting. So encourage her in between those contractions to look around the room and to pay attention to what she sees, right? She can't totally dissociate into pain if she's having to come back and name to you, oh, I see that bush outside. And maybe that's not going to be possible, but it's something worth trying because again, it's a way to pull her back to present time. Find out, especially if she's come by ambulance, if there are people who are planning to come and meet her, and do what you can to facilitate getting those people here. Name the fact that she's not in control, right? I mean, just explicitly say what's happening. And it's like, this is so hard. You're right. These contractions are just coming and you can't stop them. But does it feel really good if you stand and rock back and forth? How does that sound? Or, you know, would you like to try some nitrous? What about coming back to your breath? Losing all the labor knowledge that you have that allows her to come back to body-based control, or at least empowerment techniques. And then ask. Sometimes too, it's just helpful to know what's going on through your mind, right? And they might say, I'm going to die. I'm dying right now. And that information alone gives you a sense of where they are. And then just having more information allows you to keep meeting what's rising up in them with greater specificity, which is what they're going to need. Beautiful. Next case. All right, so we've all had the second stage. 24-year-old G2P1, 38 and 2, being induced for IUGR with normal Dopplers. It's been a long 3-day induction. She's been very stable on 16 milligrams of Subutex. She has a remote history of IV heroin use. And she's got an epidural, finally complete, pushing for 2 hours. She's crowning, and then she's just like, I'm done. I can't do this. I won't do it. Take him out. Will not push. And at that point, the baby Brady's. You have a fetal heart rate in the 70s, and she is refusing to push. What do you do? I mean, I understand we're all wishing that it's not happening, but you know that this is happening. So what do you all actually say?
I think if the doctor is wanting her to be up in stirrups, and it seems like that position might be something that's overwhelming to her, and especially with that intensity of the crowning, that perhaps we could just have a timeout and breathe and turn her, because we just think of our interventions. We know turning, side lying, breathing, just trying to be trying to be a calming presence as the nurse at the bedside, and take those stirrups down and hopefully connect with that doctor and think about what can we do together right now to help this woman, and not necessarily, I don't want to use the word force, but require an exact position for that delivery. What other thoughts do you guys have?
Sometimes I feel like in these situations, a lot of time, if there's been a nurse that's been working with her the whole time and has some rapport with the patient, that sometimes the best that I've found that works is to actually get that patient's attention and have them look at you. Like if you're the person that has rapport with them, get their attention, tell them to look at you. You know, you can even use that safe word, you're safe, you're doing a great job. It's time to get your baby delivered. This is what we need to do for you to deliver, and just really connect with them. And because sometimes there's so much going on in the room and everybody's yelling, push, 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 and the doctor's yelling, push, and it's overwhelming. And sometimes they just need one person, quiet the room, just eye contact with that patient and really talk to them about what we need to do to get their baby delivered safely.
So true. great. Well, Patty, let's go to the next slide. And you guys just named so beautifully, and you'll see that the last one on this is resource and relationship. And I couldn't agree more with Susan. I feel like when these things happen, identify the person in the room whom she's most bonded with, who's clinical, and really let that person resource into them and coach them into, here's what we need to do. You've got this, you're safe, but we're going to turn you over and you're going to push in a different direction, or we're getting a vacuum out on the table and here's what's happening, and use that relationship. Go back to your basic, what are often called trauma first aid principles. Orient to present time, continue to encourage them to have eye contact with another person or the environment, give safe physical contact, touching their body just to bring them back to it. Reinforce how resilient she is, right? This is another moment to name, you've done this for 3 days and you're doing such a great job. Honor the marathon of an induction experience that she's going through and the fact that she's had all of this that she can resource into, and carry that with her to this final literal push at the end. And of course, do some education, educate about urgent need. And I'll often say, in an emergency or in a more urgent scenario, there's a lot to talk about here, but there's some things that we need to talk about immediately and now and that are clinical, and we can talk more about what this means for you later. So honor the fact that it's a lot that's happening. Name the fact that it's a trauma, and also name the fact that there's some things that are clinically imperative that we have to take care of too. The other thing that I mentioned here is, especially with these patients who are being induced, if you've gotten the chance to develop more rapport with them over the day, maybe there's an inner source of strength that she can call on, maybe part of her own spiritual practice, her identity as a mother, or any other kind of ally that she has in her life. Next slide. And this will be our last case. So a 30-year-old G3, now P3, is post-op day 3 after a repeat C-section for Schramm at term who had no prenatal care. She came in actively withdrawing from opioids and methamphetamine, and pain control has been a difficult process over the last few days. In her prior pregnancies and after her delivery, she had voluntarily surrendered her parental rights, and she's been talking about how excited she is to take this baby home. This is your first day having her, and the rounding physician tells you to call CWS. The physician hasn't told the patient about the referral. What do you do? Or how do you approach this? Other than call the physician back and say, go do your job. That's also very reasonable.
I think since this is the first day of meeting her, the nurse could, I guess I'm just thinking, about just slowing down. We know the background situation of that. We need to call CWS, but calling CWS is not an emergency right now. I think taking a breath and taking a moment to center yourself and be ready to be present at the bedside, to just talk with her about kind of her history, whether it's appropriate, and to talk about, kind of lead the conversation into kind of what the plan is going to be for the day, and sort of present this is what's happening right now. What do you guys think? I'm just kind of going with my gut here.
Hey, this is Teresa. I always let the feel like they're being attacked. I like to let them know that this is our protocol. CWS will be coming to visit you. Again, I would have the physician talk to the patient first about the referral. And so that they're not scared, I let them know that what's going to happen. And it's our protocol, and it's just to keep make sure that the patient and the baby are going to be safe. We want to keep you and baby safe, and make sure that it's a smooth transition to go home.
Nice.
I would also make sure that we would let them know about Hannah Lippy and the Substance Use Disorder Project, the RISE project, and try to see if they are interested in being induced onto the Subutex, and also the same as Teresa, I always like to just be honest with the person and say that, you know, this is a requirement. We have to do this, and you know, that it's so that we can keep you safe and get all of the resources that you might need so that you can be safe.
And then I would say, this is Katie. I often tell them they're looking to see what kind of resources you have, like what you have, what kind of planning you've done for taking care of the baby. And I usually in that moment am telling them, look, we've been with you for 3 days, although this is my first day meeting her, but we've been with you for 3 days, let's say, or we've been with you as a staff, and we've seen you take, I look at their strengths, like you've been taking care of your baby, what positive things have you been doing? So they can kind of get the idea that part of CWS, although she has probably already had interaction, but part of it is they're looking to see what she's bringing to the table, basically, like what resources she has. Not just looking at the negatives of her life, but looking at the positives as well.
Beautiful. Those are all just such expert answers. Oh, go ahead, Gigi.
Oh, I was just going to say, we want her to know that we want her to succeed too, that we're here for her. We're not, and that what she has been doing right.
Yes. Excellent. Okay, let's go to the next slide and just talk about really what all of you said so brilliantly. And the first thing really is, how do you make your introduction to her? And slow down. Just act like you've got eternity to be there. No rush. We all know that that is flagrantly not true, but put on your actress and really just settle in and get to know her. Again, paying attention to just body posture in the room, sit down, have an eye level conversation. I'll even sometimes, depending on how much activation and reactivity I sense within a person, will make sure that I'm even sitting a little bit lower than them to make sure that some of the innate hierarchy is flipped. Ask really open-ended questions to understand her story. Again, thinking about that timeline narrative too. Present time with this baby and this birth, but also in the past. What was it like for her when she surrendered her parental rights? And what was her prior CWS involvement like? And how would she describe that experience now? Name it really explicitly, which so many of you just named, in terms of how to do that. Just name it as protocol. Partially that does put less of a burden on your personal relationship or your personal clinical relationship that you're building, but say it out loud. I think what becomes most traumatizing for patients is when CWS shows up and they haven't been informed that that would happen. That is, I can't think of a time that's ever occurred within our birth center, but it is a thing that has happened for people. I would also strongly encourage you as nursing staff to definitely pump this back to your physician and say, or whoever the delivering provider is, and say, hey, no, you need to go have this conversation too. But if this is put upon you. Find out again about other support people who are available to her. Has anyone talked to her about Hannah and about the RISE project? And does she know that there's an entire care navigation network that she could tap into? And then the other thing that I think actually behooves all of us is to have a sense of what treatment options might be available to her. Certainly Hannah is our clinical navigator and the expertise in this, but if you find out that she is homeless, it might be helpful to know, oh, hey, there are actually some residential treatment centers in Lake County and further down into the Bay Area where you could go with your baby if you don't have a place to stay and you're interested in engaging in treatment. Just being able to name that, you don't need to know that it's Thule House and you need to call Medicaid transportation or do any of those things, but knowing that they exist also frankly adds into the buy-in and the trust that that patient is building with you. So that's it from me. I am just so impressed and amazed as always with the suggestions that you all have and how clearly embodied you already get this. I hope this has been helpful in terms of maybe understanding at least a really beginning introduction to some of just the physiology of trauma, and then in terms of ways to think about concretely, how do we engage in trauma-informed care? And we can do, I'm worried that I've gone over my time and I want Hannah to have lots of time to talk too. But so we could either do a little bit of feedback and interaction now, or we could let Hannah speak and do some at the end. Patty, Kelly, do you have thoughts?
I think if anyone has a quick question, Carrie could answer it or any of us could answer that, but why don't we move ahead and have Hannah Lippy take over with her presentation. If there's any other questions that you guys have, you can just type them into the chat box. We may not get to them, but at least you've typed them in and we can answer those in an email or another format. Ready to move on? Okay, Hannah, go ahead. Thank you.
All right. Thanks, everybody. Can everybody hear me okay? I got my mask on because I'm sharing an office today. We good? All right. Cool. So what do? I just kind of wanted to give a quick overview of what happens when you guys actually refer to me. So when I get a referral, either by fax or by phone call, I try to make contact with that person right away. And when I'm making contact, I try to be as open and honest as possible. And I talk about the program is free and voluntary, and that who they were referred to or from, and ask them, do you remember having that conversation? So do you remember talking to Dr. Griffin about the Humboldt Rise Project? And if they can't remember, then I kind of talk to them about the history and the goals of the project. I do not try to keep it a secret that the project is for people who have a history with substance use. I try to really highlight that the county's trying to do a better job of preventing and kind of supporting this particular population. And then at that point, I ask them, do they want to know more? Or if they don't, that's okay. It's a free and voluntary program, and that's their choice. If they do want to know more about it, I remind them that this program is really determined by their goals. Next slide. And so the things that I try to consider before I'm going to go and talk to somebody, if they've given me the A-OK to keep going, are lots of things that Carrie's already highlighted. Like, how would I want to be treated if I was this person? I really try to slow down, watch my language, make sure I'm not using too much medical terminology, try to use person first language, which I'll talk about in the next slide. I really try to ask a lot of permission, give them some sort of control. And I'll try to be curious. I've learned so much from the people that I've worked with. And it kind of going back to those open-ended questions. There's a big difference between, has child welfare come yet, versus tell me your experience with child welfare, before they do come, and, getting more of that information. I try to give them options. A lot of people are like, what is this RISE project? So I kind of explain, some people have asked me to go to their prenatal appointments. Some people have wanted to start Suboxone or Subutex. Some people are just trying to locate food and trying to figure out that next day. And I try to not take things personally. If someone's angry at me, I just try to think of what's happened to them and then give them the choice back again. Like, okay, if things change, here's my contact number and feel free to reach out to me. I would love to help you. So yeah, I hope you can see just the similarities from what Dr. Griffin has talked about so far. Next slide. So the people first language, I just kind of want to highlight 3 different areas. So kind of looking at the green area, there's like a person with a substance use disorder. And if we compare that to the red area, an addict. So if you kind of think about, like, many of us have been affected in our own personal lives with people who have a substance use disorder. So if you think about that, aunt, your brother, your partner, your daughter maybe, and think about if someone was talking about them, what words would they describe that person? Would you prefer them using, addict, or maybe a person with a substance use disorder? Another thing that people get confused about is that mutual aid meetings. And so that's essentially looking at like NA and AA meetings. In those particular meetings, people really identify with those words to kind of remind themselves that this is a chronic disease and that this is a journey. But it's pretty inappropriate for service providers to kind of use those words outside those meetings. So I'm just going to share a couple of cases that actually have touched upon at St. Joe's. And so the first case was referred both by the nursing staff and a social worker on case management. And the information I got before I met with the person was that the social worker said that the person agreed to the program, but really thought it was only because of family pressure. And I learned that Eat, Sleep, Console was started, and that there was a tox screening that was positive for opioids, which later was confirmed by the patient. So first I like called the person, kind of checked in what was going on. She said she was really tired because she was up all night taking care of her infant, and asked if we could set up, you know, a few hours later. So I checked in back with the nurses, kind of explained I'm going to come around this time. And then they ended up calling me back around the time I was supposed to come and said, hey, you know, parent didn't actually slate, child welfare showed up. It's been a while. We'll kind of let you know. And then several hours later, child welfare called me and they're like, you know what, the patient's ready to see you. It sounds like they would like to get started on Medicaid assisted treatment. So that's when I went to go meet with the person. Okay. So maybe when Patty comes back on, we can switch this slide. But so what happened was when I met with the person, there were a bunch of family members around. And so I asked, you know, if I could come in, if I could sit down, was it okay to be open and have a conversation with her with the family members there? And I acknowledged like what they were going through. You know, you must be really tired after going through labor, not sleeping, and then having child welfare here for several hours. And at that point, we started getting into her goals, and the parent was able to identify starting Medicaid assisted treatment, trying to locate an outpatient treatment because she wanted to be able to keep her baby with her. And then she wanted help coordinating with child welfare and with WIC. So right away, we started working on goal 1. We talked about what steps needed to be taken and to start MAT. And so that the parent talked to me about like, you know, I feel really bad. Like I should have done this while I was pregnant before this, I got to let it go this far. So we just kind of talked about how opioids affect the brain and kind of use that comparison with diabetes that some people used. Then we started kind of the cows and talked about the questions. And I tried to explain the reasoning behind each question. So for instance, I talked to her about like her last use and what she used, and said like, the reason I'm asking you this is because, you know, depending on the hours, like I don't want you to have a reaction to Suboxone or Subutex. At that point, she was like, well, actually, this is when the last time I used, and she changed her answer. So at that point, I was just really proud of her and talked about like all these steps are making a difference in her life, in her child's life. So after that, then we started to figure out what we want to do with the outpatient program. So the patient said they were scared to call. So we arranged that I would call with them beside me and kind of figure out and set up a date to start when she can do intake. The next thing we worked on was like, we have to call child welfare and kind of give them an update. So then we kind of took another step and we called together, and each one of us were able to kind of let child welfare know what's going on. Then our third goal, the patient herself was like, you know what, I got this. How about I call WIC, but you're on standby in case I freak out. And she did a great job. And then before I left, I was able to see her infant either needed to get changed or was hungry, and the family like got up to like go help, and she was like, hold on, I got this. And she like, I was able to see that she had the confidence to care for her infant. So the outcome of that was she was able to start MAT. She did complete intake, and she continued to update CWS on her own, and she still has her infant in her care. So the next case is a little different. There again was referred by nursing staff, reports that there is no prenatal care, that the parents did not have a home, and the infant was in the NICU. The toxicology screen was positive for methamphetamine and cannabis, which later the patient again confirmed. So initially when I met with the patient, they were alone. They seemed pretty confused about the referral, but did accept services. And they just talked about the reason for their use and said that it was really a coping mechanism, and that they used methamphetamine and heroin. And she talked about like her ideas of what's worked in the past. And she said that at one point she tried cutting up a friend's Suboxone into little pieces, but she's never actually tried anything with a doctor, which is pretty common to hear. And so she said that she would really like to try a different, like a MAT program with a doctor, but she specified a specific town that would be close to family members who could help her out take care of that kid. So that was kind of our plan at the end of the day. Next slide. So I communicated kind of what those goals were with the nursing staff, and gave them the information that there was also methamphetamines as well. I was able to obtain that specific application for that site in that town for the MAT program. And I was able to deliver it to her in the NICU. And when I met with the patient, she just talked about like being so frustrated that felt like she was failing to bond with her child, and felt like it was because so many people were coming in and out of the room. And so we talked about that. I would help her kind of fill out the application the next day in the morning before child welfare came to check in on her. And then as I was leaving, child welfare showed up and explained that there is a safety plan. So a safety plan is created when there has been identified a safety threat, so something that needs to be mitigated. So that threat, they determined that the patient needed to be supervised by their support system whenever with the infant. And the best practice for child welfare is when there is a safety plan that they create a child and family team meeting. So some sort of space where the family can come together to make a long-term plan for that infant. So again, I communicated this information with the nursing staff, and we talked about together how the family could support the Eat, Sleep, Console in the patient's place if the patient wasn't there. The next day I arrived to kind of help with that application, and the patient said, change of plans, and asked that to have help with coordination. So she explained that like the night before, she really almost left because she felt like she just couldn't do it. And she felt a lot of shame, and she had worked with child welfare in the past and was looking at that timeline. And if an infant's under 3, you really have to make substantial progress within 4 months. And she really felt like she couldn't do that. And so she had made a plan to have her family take guardianship. So we worked together because there's lots of family members present. We got people on the phone and we made a family plan, and then we were able to present that to child welfare. And then child welfare was transparent that they would have to write a warrant to officially remove the infant from the parent and then emergency place with that family member until they could do the guardianship plan. So the outcome of that was that immediately after, the patient wanted to leave. And so I tried to talk to them just about safety and some harm reduction techniques. The patient did allow me to get them a cab to get their belongings where they were storing it, and we're able to get them a meal. But then any other time I've tried to reach out, their phone's been disconnected. And then the third case is a very short one. It just highlights the importance of screening for tribal affiliations. And so I got a call from our substance use navigator in the ED Bridge project. There is someone who is recently released from jail who needed to start Suboxone. And no screening had been done, but the patient had reported that she was pregnant. And so she agreed to meet with me. And so we actually met out right outside the hospital doors and kind of explained the plan. And she said that she was really interested in the program, but she lived outside Humboldt County and so didn't know what to do. And so I did a screening and found out that she was a Yurok tribal member. And so I explained, the Yurok tribe actually has a very similar program, and they ended up working in the county that she was living in. And so we were able to kind of make a short-term plan and got consent to be able to coordinate with the Yurok tribe and provide transportation so she could get back to that county. The outcome of that one was that she was able to enter an outpatient program in her home county. She continued her medication, and she was still working with the Yurok tribe. Okay, so I know COVID is another big stressor. It's like Carrie said, almost like an extra trauma, like a global trauma on top of what's already happening to people's lives. So Carrie's already talked kind of about the fight, flight, freeze, and just kind of wanted to bring this up that this might be coming up for people even more, that depending on people's level of fear with COVID, our brains will direct us to particular behaviors. So if we look at like the mental state and our responses, if someone has had a plan, they've met their midwife, like they've met some of the nurses, they feel good, they might be during like an assessment that you guys normally do, be able to reflect and really answer those questions. If someone's more on alert, like what's gonna happen, maybe they don't have a full understanding of COVID. They might do more of a tendency of flocking. Flocking is more kind of like surveying, like what does the rest of the room think? What is the community doing? Are people wearing masks or are they not? So there's different behaviors, and depending where they are on that spectrum will kind of show you what behavior might be coming out of it. So just to show again the importance of creating a calm and kind of transparent environment during this time of crisis. There's a lot of resources that keep changing with COVID. I would just highlight, like, check in with your social workers if possible. But some things that are happening today, President Trump signed into law the additions to the CARES Act. So that's going to help more small businesses, and did include $75 billion for hospitals and $25 billion for disease testing. At a state level, people now can use some of their CalFresh EBT to make online transactions. And then for California, there is some cash benefits for undocumented households. And then locally, we have a lot of stuff happening. Up in Arcata House, they have 2 areas set up for people who do not have homes that can set up their tents. There's the County Home program that are housing people 65 and up with comorbidities. And then even within St. Joe's, a lot of our community resource centers are all still running and helping their community to best fit their needs. So for instance, some places are doing delivery of food. So again, there's so much happening. There could be a whole webinar on what kind of resources there are, and they keep changing. Just keep checking in with your social workers. Susan.
Okay, I just wanted to, I think everybody has probably seen the resource binder that I created that's at the desk that's for the RISE project. And it's got everything you need in it that has anything to do with going from the referral form to get somebody connected with Hannah. It's got all kinds of information on, it's got information on how to do cows, information on the protocol for starting somebody on Suboxone, Subutex. It also has the all of our local resources. So I would just encourage everybody to look through it. It's right at the desk. It's a white binder it has a little baby feet on the cover. And also I just want to mention, and I will put this in the binder. I don't know if it probably is on the flyer in the binder, but this resource hub, this web link over here is really a great online source of everything that's available in our community that the RISE project put together, and I would encourage people to look at that as well. And I think that's all I'm going to say about that, because we're kind of running late and I want people to have time to ask questions.
Yeah, thanks, Susan. So the resource hub, we're going to send these slides around, and you can click on the link, or it's resourcehub.enshin.org, and it was created as part of this grant. So it has a specific focus on pregnant women with substance use disorder. So please take a look at that resource, and please let us know what questions you have. I know we're at time, but if you can hang around, and if you have questions, we're happy to answer.
Okay, I think the sun might be causing people to feel like it's 3 o'clock and time to go outside and continue with the day. I just want to thank everyone for attending and our speakers. It was an amazing talk. This is just the beginning. We're hoping to have another workshop, later in the year, and we'll see what happens with all this COVID stuff. We're a strong team, and we got this, and I'm proud of everybody. And so if anyone has any other questions or concerns or anything that they want to continue talking about, just feel free to email Susan or I, and then we can bring that information or we can bring those questions to Carrie, Dr. Griffin, Susan, or Hannah. Thanks, everybody. I appreciate it. Enjoy the day.
I see that Rose asked if there was information about the RISE project on the unit, and maybe that was before I talked about the binder, but it's all in that binder, Rose, and there is a lot of information there.
Thanks.
Thank you, everybody. Thanks for logging on today.
Thank you.
Goodbye. Thank you.
Thank you. That was great.
Thank
Thank you guys.
Very informative. Thank you.